and address them during the question and answer session at the end of the presentation today. So it is also my great pleasure to introduce our speaker for today as a moderator, who is going to present on a colorectal carcinoma resection reporting PROFORMA, what's new. So Dr. Pavirada holds a Master in Pathology from University Kebangsaan Malaysia in 2012 and has enjoyed a fulfilling career as an anatomic pathologist, beginning in 2012 with 11 years of experience in this field. She then pursued a subspecialty training in GI and hepatobiliary pathology at Hospital Sultanah Bahia, Hospital Selayang, and Royal Free Hospital London from year 2020 to 2021 under the guidance of Datin Dr. Nick Raihan, Dr. Sami Abdullah, Prof. Alberto Quelia, Dr. Jennifer Watkin, Prof. Roger Fakins, and Prof. Tu Win Long. She is currently working in Hospital Pulau Pinang and has developed Hospital Pulau Pinang as the referral center as GI and hepatobiliary pathology. She received many referral cases from all over the Malaysia. Dr. Pavirada has been an invited speaker in many workshops and conferences, as well as actively involved in case publication throughout her career. Without further ado, please join me in welcoming Dr. Pavirada. The floor is yours, Doctor.
Thank you, Suguna. I would like to thank IAPMD for inviting me to give this talk. And thank you everyone for joining us today on your weekend. I just want to, okay, let me share my screen. Right. Can everyone hear me?
Yeah, Doctor, we can hear you.
Okay. Right. So once again, thank you. So as everyone has, who has been in the histopathology line, we have been using the colorectal PROFORMA for resection specimens since somewhere at 2009 onwards, after which Dr. Nick Raihan had come back from her overseas attachment. She created the PROFORMA at that point, and her PROFORMA actually was based on the Royal College of Pathologists, the UK data set. So as years progressed, from their first edition to their fourth edition, we have been updating that PROFORMA. And in 2012, when we had the National Anatomic Pathology Workshop on PROFORMA reporting, it was introduced to all the hospitals in Malaysia. And from that point, it has been adopted. So most of the hospitals currently in Malaysia are using the colorectal PROFORMA, which was created around 2000, I think latest update was around 2011 or 2012. And that is the one that has been used. However, there has been updates, and the latest data set was updated in 2018. So based on this latest data set, Dr. Nick, myself, and Dr. Sakina had worked on updating the PROFORMA in Alostar Hospital, Hospital Sultanah Bahia, and we have actually been using it since 2020. But I think it's time to introduce it to everybody so that you can start using it in your respective hospitals. So basically what I'm going to talk about is these changes, and I'm also going to touch about certain salient points in processing and reporting that are not new, just a refresher for everyone. So let me start. So colorectal cancer in Malaysia is very, very common. It's one of the most common, second most common cancer among the general population. And it is the most common cancer among males and second most common cancer among females, next to breast CA. We see more males than females, and the incidence is highest among the Chinese compared to the Malays and followed by the Indians. And we find that more than 70% of colorectal cancer patients in Malaysia are diagnosed late, either in stage 3 or stage 4. And this has actually led to the new protocols for cancer screening, colorectal cancer screening in Malaysia, the CPG, which came out last year. So previously, in 2018, the National CPG for Management of Colorectal Cancer was created by our colorectal surgery colleagues and our gastroenterology colleagues in Malaysia. Okay, the PROFORMA, as I mentioned earlier, was created by Dr. Nick in around 2019, was introduced in the workshop in 2012, and then in 2018, it got incorporated into the National CPG of colorectal carcinoma. So now, when that happened in 2018, we were already working on this new PROFORMA, but we decided to stick to the older PROFORMA initially because it was just introduced into the CPG. We didn't want to make any changes at that point. But now I think 2 or 4 years on, I think it's time to move on, right? So this latest update is based on the histopathology data set, which was published in September 2018. This is the 4th edition, okay, the Royal College of Pathology standards. There are new information and data which have been shown to be important and should be included in the report for prognostication. Reports, let's standardize them. So now some hospitals that I have gone to, I've already introduced this new PROFORMA, but the other hospitals are still using the old PROFORMA. So we have a little bit of discrepancy on the things that we are reporting. So I think it's time we all standardize this in our different hospitals, right? So the old template has been changed in 2020. Why is it important that we keep updated and why that we maintain the quality of our reports? First thing is a good report confirms that we need why this surgery was done, whether it was really necessary in the first place. Then to correctly stage the disease for accurate prognostication and appropriate post-operative therapy, okay? We have to look at lymph node involvement or tumor deposits. I will be talking a bit more about tumor deposits because when you have lymph nodes or tumor deposits, then we need to give patients adjuvant chemotherapy. When there is no lymph node involvement, then just give me 1 second. With adverse pathological features such as venous invasion, perforation, peritoneal involvement, margin involvement, or extensive local spread, then these cases will also be offered adjuvant therapy. So all this information we must include in our reports. Rectal adenosis with circumferential resection margin involvement. These cases have been proven to have high risk of local recurrence. Again, it's to decide whether to give pre-operative or post-operative adjuvant therapy, right? And furthermore, these reports can be used to look at the quality of cancer surgery that is performed, especially like the CRM involvement It's actually to audit the surgeons whether they've done a good job in surgery. So these are the changes that have come up with the 4th edition, right? They have defined tumor deposits, which previously was not well defined. And it says there must be no nodal, vascular, or neural structures. And we don't look at size anymore. Previously, we were looking at 3 mm size, but now we don't look at these things anymore. Then we look at assessment of peritoneal infiltration as a quality of standard, which we did previously, but now it's no more important, right? We have changed from 7 TNM to 8 TNM reporting, which is about time, I think. Previously, the reports included either Duke's or Passey's classification, but now it's no longer reported because it has, they don't think it's not anymore relevant to their management of the patient. Number of tumor deposits, previously we didn't report number, but now we report number up to 5 or more than 5. We don't need to give a specific number. Honestly, it's impossible to count. So when you see less than 5, okay, fine, you can give a number. When more than 5, it's usually everywhere. So we just write more than 5. Depth of venous invasion, previously we were reporting as submucosal, intramural or extramural. Now we are going just to extra and intramural. Presence or absence of perineural. This was previously a non-core data item, but now it has been changed to become a core data item. And lymphatic is not bundled with venous, okay? We always say lymphovascular invasion, but now it's actually separated. And you have to again report it as extra or intramural. I'll go through one by one here. Assessment of tumor regression. Previously, we had no well-defined scoring system, but now they have advised us to use the modified Ryan score, which is a 4-tier scoring system from 0 to 3. So this Ryan's is what they find that most correlates with the TNM, the 8th edition, and also the treatment for patient. So let us compare the old PROFORMA versus the new PROFORMA. Let's start with the macroscopic and cross description. Honestly, not much changes. This is the old PROFORMA here, and this is the new one. Most of the information is the same, okay, except maybe in the length. We've said separate measurements for small and large bowel. All the types of specimens is the same. The site of tumor also is the same. It's allowance for free text, right? Maximum tumor diameter, which is only single rectal measurement. Some centers still tend to give 3 measurements. You don't need to. Maximum tumor diameter is what is most important. Anyway, it does not affect the TNM staging at all, right? Cross subtype, fungating, ulcerating, ulcerofrangating, and anything else you feel like writing, if you feel it's fine. It's just a cross description. So this possible deepest tumor infiltration is what has been introduced, and this is just eyeballing. That's why we say possible deepest tumor infiltration. It's just an observation, right? And later you confirm it microscopically. In the margins, what I found that a lot of times, because the older PROFORMA did not mention circumferential margin, we rarely put circumferential margin in the description. So here we have included the circumferential and non-peritonealized margin. Tumor perforation is there, right? Rectal tumors, all the same data is there, polyps, number of lymph nodes. We have included some notes: lymph node harvesting, a minimum of 12 lymph nodes requested. Harvest all lymph nodes, do not stop at 12. This is multiple times it is repeated throughout PROFORMA. So, points on specimen handling. So, some important things. This is what is ideal. Most of the time we don't do it. When we receive it, it should be fresh and unopened. But in our sitting, specimens are usually sent the day after the operation, or sometimes the weekend after the operation. So we have advised our surgeons locally to please open anti-mesenteric longitudinal to the tumor and send. Okay, if that is possible. But if you are receiving your specimens fast, like the day after, then usually we tell them, please don't touch the specimen, let us do the crossing. Okay, microscopic examination, of course, type of specimen, tumor location, whether there is true and true perforation at the tumor or distant from the tumor. This is important because if it is at the tumor, then it makes a difference to your T staging. But if it is away from the tumor, this is secondary perforation, secondary to, say, obstruction, dilatation, and perforation, then this does not count as perforation. Yeah. Plane of surgical dissection in anterior sections and APE specimens. Of course, there's circumferential margins, which is also a non-keratinized margins, right? Macroscopic core data is nature of specimen site. These are the things that I mentioned. Additionally, your longitudinal resection margin distances, a relation of tumor to peritoneal reflection. All measurements are in millimeter. So types of colorectal specimen is always nice to print this out and give this to your MO who's doing the crossing, because then they know exactly what they're looking at and can orientate, right? Mm-hmm. Yeah, so these are all the specimens that you will receive from the colorectal specimens. How do you open the specimens? As I mentioned, open anteriorly or antimesenteric, sparing the tumor area 1 to 2 cm above and below 2. Place absorbent paper foam in the lumen, fix for 24 to 48 hours. Usually we do 24 hours. Transfer slicing through the tumor, identify depth of invasion, lymph nodes, vascular invasion, and CRM. So if this is the segment that you get and the tumor is in the center, you open this way, antimesenteric, and then you put a wick through, and then you slice it this way at the tumor site. This allows you maximum visualization of the depth of tumor. Remember, depth of tumor is what we need for TNM staging. Any other way, you might not get the deepest invasion. You will miss the lymph nodes. Okay, this way you get nice cross sections of the tumor going into the muscularis propria. You will get nice lymph node or tumor deposits observation, and you will also get margin, your circumferential margin view. So this is the best way to cut it. Okay, I know that the PROFORMA says you cut it this way and that way, the data set. But I personally like cutting it all the way across on the antimesenteric side, having a look at exactly where the tumor is, and then slicing it this way. And put your tissue paper in between, or your gauze, whichever one you use, and then you let it fix. So when we're looking at resected rectums, the peritoneal reflection is the most important thing you want to decide on. where it is, because we need to report whether the tumor is above, at, or below this rectal in the anterior resection specimen. So how do you decide where is the peritoneal reflection? First and foremost, decide where is the anterior surface and where is posterior surface. Okay. So the anterior surface is covered by peritoneum down to the peritoneal reflection. So it has this kind of V-shaped or U-shaped appearance. It's smoother at the top and rough at the bottom. This becomes the mesorectum area. Posteriorly, the V is inverted, right? So this is all peritonealized surface and this is non-peritonealized surface. And usually this has a tie at the top where you can identify the vessels are tied or clipped most of the time, and you have the highest lymph node there, right? Here, and it comes down. So all these parts actually are non-peritonealized. So you have to be certain where. When you say tumor is at or above, anything above here is above peritoneal reflection, at is here, and anything below this is below the peritoneal reflection. That is how you have to look at it crossly. So this is an example. So this is anterior surface. Specimen has already been sliced open. Tumor is sitting there, right? So this is antimesenteric, yeah. So you can see smooth peritonealized surface. So this is where the peritoneal reflection is. Sorry. Peritoneal reflection is, right? Anterior. Now this is the posterior surface. This is the anterior surface. So you can see it has this V shape. That's where it is tight. The vessels are tight. And this is your high tie area, where your vessels need to be sampled and your lymph node you'll start looking for your lymph node there. And all this is non-peritonealized or circumferential resection margin. So even though your tumor is at the upper part of this part here above the peritoneal reflection, if the tumor is on this side of the specimen, you are going to have a circumferential resection or non-peritonealized resection margin. So remember, this doesn't mean that it is above there. You are going to have no circumferential margin. You will still have it. Yeah. So this is important. And have this picture in your mind every time you're crossing. This is a very beautiful specimen. Sometimes we get it, we don't get it so nicely. And it's quite difficult to decide where the reflection is, especially when you have other structures stuck to it when they do pelvic exenterations and things like that. So this I've already said, described to you. So if it's here, it's above. If it's at the peritoneal reflection, it's here. And if it's below, then it's below. So the definition of it is all based on looking at the specimen from the anterior point of view, not the posterior, right? To decide this information for your reporting. Why is this important? Because tumors below the peritoneal reflection have highest rate of recurrence, and this is level evidence A. Okay, so very, very strong evidence that this is important. So plane of excision. So plane of excision for anterior resection. Your mesorectal, intramesorectal, or muscular is propria. Mesorectal, very beautiful, smooth surface. Looks nice and bulky. There's no coning, there is no defects. Even if there's defects very, very small, honestly, anything smaller than 5 mm, you're not going to be able to see it, right? Then intramesorectal is when you start seeing some amount of coning, Okay, there is moderate bulk of mesorectum, but it's not so beautiful and shiny like this. So this is intramesorectal. There is some minor irregularities of the surface and some amount of coning, right? You see a little bit of the bulk is reduced. So muscularis propriatis is the worst kind because obviously the tumor will be perforated in this kind of cases. You don't have adequate circumferential margin resection. Okay, these cases almost 100% end up having local recurrence. Okay, substantial area is missing. You don't have any fat covering. You see muscle. So muscularis propria invasion. Depth of excision for APE. APE is, if you see very nice, smooth outside, you see the extralevator muscle here, then this is extralevator. Sphincteric, when you start seeing waist coating. Okay, you have a cone of waist like that, then it becomes sphincteric. You don't see the extralevator. Once you start seeing intrasphincteric, submucosal or perforation, then you report as that. So standard blocks, you have 5 blocks of tumor minimum, and this includes everything: deepest invasion, peritoneal surface, vascular invasion, and adjacent organ should be sampled. If it's a very large tumor, then you take more. But honestly, 5 blocks is more than adequate for reporting. Okay, if you have tumor or tumor deposits with the circumferential resection margin, take this because you need to measure and report it. If distance is too far, you may not need to sample and just use microscopic measurements. I tend to still sample wherever, how far the longitudinal margins are. I feel it's better to always have a record. We don't know 10 years down the line when this patient has some complications or decides to sue anybody. We don't have any more blocks or slides. So I'm a little bit more careful that way. So I still do sample the proximal resection margin, distal resection margin, and the circumferential margin. So that at the point that I am not working anymore, if there is any query, we can always look back at these cases and make decisions at that point. So for minimum sampling, if you have lymph nodes that are less than 4 mm, submit as whole. If they are larger lymph nodes, take 1 cross section, take micrometastasis. If you see micrometastasis, then you need to again go back and submit entirely. But usually if they are very large lymph nodes and you see metastasis, you're quite convinced on grossing, just take one section. Right hemicolectomy specimens, take 1 block of the appendix and 1 block of the ileum. If you see peritoneal involvement, dull fibrotic areas, then at least 2 blocks of this. Look for vascular involvement and sample. Note where it is intramural or extramural. So lymph node is one of the most common questions I get asked, usually through WhatsApp. How do I identify the lymph node? Okay, first thing you want to look at the highest lymph node. Always start with your highest lymph node because you need to identify that first. The highest lymph node is look for the thigh area and then cut your way down. And the first lymph node you find is the highest lymph node. If you have 2 lymph nodes there, sample both. Highest, so look for the one that is the first. The first one you touch is highest lymph node. There's no other way of definition for this. So that is your highest lymph node. Take. If you see 2 very, very close, then you pick which one you think is higher. The other one you put as normal lymph node. It's fine. Right? Block this separately. Okay, a lot places, don't block this separately. Please block this separately, because positive highest lymph node have worse prognosis, especially in patients with stage 3. So if your patient is a stage 3, then they need to know whether the highest lymph node is positive or not, right? This will also determine whether these patients get chemotherapy or not, right? Look for remaining lymph nodes after that by slicing transversely and looking. Some people put them in some chemicals to dissolve the fat and all these things. We don't have them in any hospitals here. So we just have to use eyeballing and slice them thin, find all the lymph nodes. Don't stop at 12, right? If you find a lymph node that looks positive and it is close to the circumferential resection margin, sample it with the circumferential resection margin, because your distance to circumferential resection margin will be from this lymph node, not from the main tumor and its deposits, right? Sample all the lymph nodes as I mentioned. In cases, 1 minute, let me see whether I can post this. Yes, okay, right. So in post-neo-adjuvant therapy rectal tumors, these are very, very common now. We get them almost every week. Any rectal tumors, they have shown that giving them neo-adjuvant therapy actually improves survival and reduces local recurrence, right? Okay. So sampling and reporting of these rectal tumors. First thing, you take minimum 5 tumor blocks from the tumor bed. Okay. If you have tumor present, good for us, easy to report, not good for the patient. So you report as usual and you give tumor regression score. If you do not see tumor, then you do 3 levels for each block, right? 3 levels of each block. If still after these 3 levels of each block, you still did not see tumor, then you need to go back and recross and entirely submit the tumor bed. If again you see tumor, okay, all right, so then you report as usual. But if there is no tumor, then this entirely submitted, you need to do another 3 levels for each block. So if you have done, so 5 blocks here, 5 times 3, 15 here say you have another 5 blocks, then you have another 15. So that's going to be 30 slides for you to review. And only after you do these 3 levels, if there is tumor present, then again you report as usual. But if you don't see tumor, then you can report as no residual tumor and report as complete regression. Microscopy. Okay, let's move on. So now histology. There is quite a few changes in the histology part. So we'll go through them one by one. The first one is a type. Previously, we reported as well, moderate and poorly differentiated. Now we are going into low grade and high grade based on the WHO latest edition, 2010, 5th edition. And the well and moderately goes under low grade, and the poorly differentiated goes under poorly differentiated. Okay, high grade, sorry. Then there is additional features that we want to look at, which is tumor budding. In tumor budding, you look at low, intermediate, and high grade. Yeah, I know, tumor budding, oh my God, what's that? Don't worry, I'll talk about it, okay? Then the other information is all the same as previously there. We have included small notes. I'll show you the notes at the rest. So for 2.2, see note 1. for 2.3 is in note 2. Okay, the last page has lots of information pearls on how to use this PROFORMA. Local invasion has an addition in PT4A. PT4A previously was just tumor cells has breached the serosa. But now for rectal tumors, we look at perforation below the peritoneal reflection, meaning if your circumferential resection margin is involved, previously it used to be a PT3, but now it becomes a PT4A. Okay, so tumor invades adjacent organs. This is the same PT4B as previously. Then, as I told you, that there's a tumor regression score now, which is 2.6, slightly different from previously. It was not so well defined. So now it is more well defined and you have a score to give. Virtually, so tumor type, virtually all colorectal carcinomas are adenocarcinomas, NOS. There are a few other types, your signal ring cell type, where you have to have more than 50% signal cells, okay? And this is a stage-independent adverse prognostic significance for this patient. Again, mucinous carcinoma, you have to have more than 50% mucinous morphology. Remember, in those patients that have received pre-operative therapy, this may induce a mucinous phenotype. You see this quite often. So don't change your diagnosis from an adenocarcinoma from the biopsy to a mucinous carcinoma in your resection specimen. Or in these cases, you have to look back at the pre-operative therapy and decide what type of adenocarcinoma it is. Okay, patients who have, remember this is important, don't change the diagnosis from an adenocarcinoma NOS to a mucinous carcinoma, because when they receive pre-operative therapy, they can have mucinous differentiation, becomes more prominent, maybe more than 50% of the tumor. NETs carcinomas or medullary carcinoma, undifferentiated carcinomas, these are all there. So the WHO 5th edition has changed your mixed adenocarcinomas and neuroendocrine carcinomas. So here now we have to have at least 30% of each component before you call it a mixed type. In those patients with MMR deficient or MSI high tumors, most of these cases normally have mucinous differentiation or medullary differentiation. Okay, sorry. Differentiation, sorry. Based on architecture, as I mentioned to you, now it becomes 2 grade. So this is because it enhances agreement between the pathologies and also quality control is much better. So it's either low grade or high grade. Okay, and this is level C evidence. Tumor budding. Let's talk about tumor budding. Tumor budding, increasing recognition as an independent prognostic factor with adverse clinical outcomes. There are 2 types that have been identified, but for our histological reporting, it doesn't matter. Well, we don't really report yet whether we have to say peritumoral or intratumoral. Okay, in these 2 groups, that means they found those with intratumoral tumor budding to be non-responsive to neo-adjuvant therapy and has decreased survival, so poorer prognosis. High-grade tumor budding is defined as 5 or more foci of isolated cancer cells. High-grade tumor TB shows aggressive clinical pathological features. These patients have lymphovascular invasion, higher tumor grade, infiltrative tumor margins, lymph node and distant metastases. Why is it important? In patients with stage 2 disease, these cases get given adjuvant therapy. So there was a consensus done in 2016 for tumor budding, and they came up with some guidelines, okay? And these were all incorporated in CAP, RCPAT, and RCPA cancer reporting protocols. So definition, a single tumor cell or a cell cluster up to 4 tumor cells. 4 tumor cells, anything more than 4 tumor cells becomes a tumor deposit or cluster, what you want to call. But tumor budding is only up to 4 tumor cells, single to 4. Okay, how to assess tumor budding? First thing, look at H&E slide, not IHC slide. IHC is messy, difficult to decide. Look for one hotspot. Remember, you need to know your eyepiece diameter. Most of our eyepiece is either 20 or 22, right? Look at your microscope. The assessment is done at times 20 objectives. If the microscope does not have a times 20, go look for a microscope with a times 20. If you are using a 20 eyepiece diameter, then your specimen area becomes 0.785. Okay, and remember what is the normalization factor. So for an eyepiece of 20, your specimen area is 0.785 and your normalization factor is 1. So these are all the information you need to calculate the tumor budding score. And the score is 3-tiered, is either low, intermediate, or high. So this is what I'm repeating myself. Okay, H&E, look at your objective at times 20 or objective, right? How do you decide hotspot? Look at times 10 objective, find areas at the edge of the tumor, right? The invading part, and look at 10 fields. And then you have to decide within these 10 fields whether it is, which area looks more. And then you count that one area at times 20 objective. Okay, so after that, once you screen, you found a place that has the hotspot. Now you count there. Once you count, then you take that count, you put it up there, and then you divide by normalization factor. So if you're using a times 20 eyepiece, then your normalization factor is 1. So based on that, you give it a low or intermediate or high score. Okay, I'm going to show you an example. So reporting it, as I mentioned, if it's 0 to 4 is low budding. If it's 5 to 9, intermediate budding, and 10 or more is high budding. So let me give you an example. Important points, eyepiece 20 mm. Then your tumor bud count per area is this. And you look at it at times 20 objective. Scan 10 fields. If you have 10 fields, sometimes it's biopsy. You don't have 10 fields, so you will be less. Then you identify the hotspot, count at this hotspot. So say on this one case, you find 5 tumor buds. So the bud count will be bud count at 20 times objective divided by the normalization factor, which is 1 in this case. So 5 divided by 1 is equals to 5. So you get intermediate budding. Okay, that's how you report it. So now let's move on to local invasion. There is changes mostly affecting the PT4 stage. I told you that the PT4A, if tumor perforates visceral peritoneum, then, but it has to be direct invasion, not tumor deposits, okay? And for rectal tumors, if it has perforated below the peritoneal reflection. And PT4B is still the same, tumor invades adjacent organ. So it, as I mentioned earlier, involvement of peritoneal surface, there is risk of intraperitoneal metastases, and involvement of the CRM, risk for local recurrence. So this one is how you measure. As I told you, if the main tumor is here and you see distance of spread will be from muscularis propria to the deepest invasion, from the non-peritonealized margin to the tumor or to a tumor deposit. Okay, don't forget, it can be a lymph node, it can be a tumor in vessels, or it can be a tumor deposit. So when you sample, you make sure you sample the most closest thing to the CRM. So make sure you sample your CRM before you go lymph node hunting. If not, it's going to be a headache for you. Response to preoperative therapy. So again, this response is only based on presence of tumor cells. It's using the modified Ryan score. Complete regression is reported as YPT0, YPN0. So these are the four groups. If they don't see any viable cancer cell, it becomes a TRS0. If you see single cells or rare small groups of cancer cells, a complete response. If you see residual cancer with evidence of tumor regression, but more than single cells or rare small groups of cancer cells, then it's partial response. And if there is extensive tumors, but no evidence of tumor regression, such as all these things, fibrosis, hemorrhage, necrosis, inflammation, then this is poor no response and becomes TRS3. Okay, let's move on to metastatic spread and deepest level of invasion. So these are the two. It was already there, but there is certain additions to this or changes. So metastatic spread, look at lymph nodes. Previously, if we had isolated tumor cells, we were supposed to report them. It becomes PN1. But now they have found that if your isolated tumor cells in the lymph node is less than 0.2 mm, then this becomes classified as N0, no N1. Okay? Because they find that in the long run, there is no change for these patients. Only it becomes micrometastasis. Last time we used to report as PN1 MI. Now there's no more that. As long as there is metastasis, anything bigger than 0.3 mm, it becomes a PN1 for these cases. So PN1, this hasn't changed. PN1 is 1 to 3 lymph nodes. 1A if more than 1 lymph node positive. If N1B is 2 to 3 lymph nodes. PN4, is 4 lymph nodes onwards, and then again divided into A and B. Look for highest lymph node, sample and block separately. Preoperative therapy, if given, this includes signs of regression. Look for fibrosis, necrosis, or mucin. Only if you have viable tumor cells is it considered that that lymph node is positive. Do not report mucin, necrosis, fibrosis as positive for metastasis. Only viable tumor cells, yeah. However, this does not apply to preoperative lymph nodes. If they're if you see pre-op lymph nodes that have mucin, you consider these positive. Other things, okay, tumor deposits. So these are discrete nodules of cancer in the mesorectum or pericardial fat, and they are discontinuous from the primary tumor. You do not see evidence of lymph node, vascular, or neural structures. When you do not have lymph node positivity in these cases, then you have to report them as PN1C. That means in patients that you don't have lymph node positivity, but you see tumor deposits in the perirectal fat or mesorectum, then it becomes PN1C. And now you report them is up to 5 or more than 5. That's all you need to tell them. Obviously, the ones with more than 5 have poorer prognosis. These cases go for neoadjuvant therapy. Previously, the DNM 5th edition said 3 mm rule. If the thing is 3 mm and bigger, then this is a nodal metastasis. This no longer is used anymore, right? So what about biopsy confirmed distant metastasis? Look for presence of histologically confirmed distant metastasis, and it should be, site should be recorded, okay? Lymph nodes that are separately sampled away from the tumor, para-aortic, para-ileal lymph nodes, those are separate. These do not come under your N classification. These become under your M classification for reporting. So colorectal cancer for PM1A. If you see metastatic disease in one distant organ, so this is excluding metastatic peritoneal disease. So there's no peritoneal disease, then you get 1A. If you have 2 organs or more distant organs, then it 1B. If you don't have involvement of distant organ that has not been sampled, then, but you see metastatic peritoneal disease, then you say M1C. Even if you have all this and you see peritoneal disease, then it be M1C straight away. You can only assess if these specimens are submitted. Don't write PMX anymore. It doesn't exist in TNMA. So if you didn't receive, then you don't write M staging. You don't write the PM. Okay? You just leave it blank. So only the T and the N in those cases. However, if you have samples from distant sites, then you need to put in the M staging. Venous invasion is a very independent prognostic indicator, and you look for extramural involvement. Usually you have a muscle coat that you can see. You sometimes see an artery adjacent to it. So then you know, okay, this is possibly a vein. They say you can use elastin stains. Honestly, it's not really recommended. Usually it's just eyeballing. If you have an MRI, then look at it. Previously, we reported, as I said, is either submucosal, intramuscular, extramural. Now they say it doesn't make a difference. So just if I did into an extramural or intramural. Lymphatic and perineural now are reported as separate entities. So make sure you look at small vessel invasions. And most of the time, these patients will have lymph node metastases. Okay, need to mention level of involvement. And honestly, if you have positive nodal metastases, then obviously you have extramural lymphatic invasion. So sometimes, even if you don't really see it, you can pick the extramural lymphatic invasion. Obviously, it has to go through the lymphatic channels to go to your lymph node. Okay, except if you say direct invasion, that means the tumor is directly invading the lymph node, then you don't go and put it as extramural lymphatic invasion. So throughout my talk, I have mentioned TNM8. So we are moving from 7 to 8, but we have still included 7 because the national CPG still uses the 7th edition. So in our reports, we have just left both TNM 7 and 8 edition 1. The other thing that we left there, even though the data set has said stop using modified Duke stage, is that we have still left the modified Duke staging, because when we spoke to the colorectal surgeons, who came up with the CPG, their management is also still based on Duke stage. So we still report the Duke stage. For me, I advise you to speak to your local colorectal surgeon and decide what staging we want to use. The newer surgeons all use the DNM staging. Some of the older ones, more senior ones, they still want Duke staging for their cases and to make decision on management. Don't forget the oncologists. They are also important when you adapt this colorectal PROFORMA to your local. Next thing is the mismatch repair, right? This was already pre-existing, but I want to talk a little bit about it. Okay, so MMR deficiency is found in about 15% of colorectal cancers, and most commonly is sporadic, but occasionally it's associated with germline MMR gene mutation, which is Lymph syndrome. This is about 3% of colorectal cancers. Okay, what is important is MMR deficient tumors have a better prognosis than MMR proficient tumors. Okay, so it's a positive thing if these patients have MMR deficient tumors. There's two things why you want to look for MSI, MMR deficiency in these cases. Previously, we were all doing it to identify cases with Lynch syndrome so that we can look at their family, we can look at prognostication that way. But now in the latest studies, we find that those patients who have deficient MMR status, their response to certain chemotherapy, 5-FU-based chemotherapy, which is usually the first line for colorectal cancer, is not as good. And so they need to add on an oxaliplatin chemotherapy regime, like FOLFOX in these cases. When this study, when this data set was done, this statement is from the 4th edition data set. The evidence was not yet there. But now, after the 4 years, there are many studies being done, and some that have been done have actually shown that this is true. And the new protocol suggests that all patients be done, have MMR status evaluation. So deficiency in MMR stages can be evaluated either for MSI testing or IHC. Honestly, if you can, I suggest that you start doing this for your cases. This is important for the patients. Okay, in NICE, NICE has issued a recommendation in 2017 for universal testing at the time of diagnosis for all colorectal cancers to detect Lynch syndrome. Other testings that are done are your RAS studies, which are KRAS and RAS testing, BRAS testing, and which is usually an extension of the MMR status. Okay, and all this affects these patients' chemotherapy regimes, their prognostications, depending on their stage 2 or stage 4 cases, where they want to decide what chemotherapy to give. So this is the current thing. Just give me a few minutes more. All newly diagnosed colorectal cancer get IHC testing. If it is normal, then you don't have to do anything. If you see loss of MLH1, then they need BRAF mutation and testing. Okay, if it is positive, then it becomes sporadic MSI. You don't have to do anything anymore. If it is negative, then you have to check for mutation for MLH1. If this is positive, then it becomes confirmed Lymph syndrome. So these patients go for appropriate genetic testing and all those things, and family germline screening and all that. If the MSI is abnormal, there is loss of PMS2, MSH2, and MSH6, then again you go for which type. If these are loss or there is mutation, then you look for negative and IC with MSH2 loss. So the IC is actually quite good. And here you see genetic deletion or IC by APCAM, and if positive, then it goes to Lymph syndrome. If negative, then you just send them for clinical management. Sorry, my slide is not moving. Okay. So now the latest one, sorry. Yeah. In cases that MMR is positive, then these are considered MS as stable tumors. Then you have IC, which is normal. And if you do BRAF testing, then this is likely a sporadic CRC. Okay, if it is mutated in the BRAF mutation, then it is likely sporadic, but these cases have poorer prognosis. If it is deficient and you have loss of the MSI with BRAF mutation, then you become sporadic CRC. These patients have reduced benefit of 5-FU. If there is loss with intact BRAF, okay, then, and you see all the sequencing that is lost, then you confirm Lymph. These have good prognosis, but reduce 5-FU benefit. So again, you have to give them the other chemotherapy. And in those cases that have metastatic disease, you actually do EGFR and KRAS mutilation analysis. And based on that, they give the appropriate chemotherapy. So the large face in this PROFORMA actually has a guide for all the changes. Everywhere there is notes, and they give you all the information for you to look at. So this is to make life easy for all of us, because everybody's not going to remember all the things that I pointed out. But all the information for the changes and how you do how do you use this PROFORMA and how you report is all there in the last page of this colorectal PROFORMA. These are my references, and I want to say thank you for Dr. Siti Sakina Sobri and Dr. Nick Raihan, who were instrumental in the updating of this PROFORMA and this presentation. Thank you.
Thank you. Thank you, Dr. Pavi, for the insightful and very comprehensive talk covering from the anatomy and also up to the microscopic reporting, touching very specifically the areas that we found quite difficult in reporting, especially I think the tumor budding, the method of assessment of the tumor budding. Personally, for myself, I found it is a bit difficult, but you have really touched it very well. And I think after this, I can seriously start applying the tumor budding method of assessment in colorectal PROFORMA. I think we have a few questions. I think I share the screen and then we'll go through the. Yeah.
I will try my best to answer them.
So for the first question, we have from Dr. Nur Hafiza.
Can you make it bigger for me then? It's gone off. I can't see the question.
And can see now?
Okay.
Okay, right. So, for the first question.
Okay. Thank you for the PT question. Okay.
For PT staging, it should be based on deepest invasion of the main tumor, right? How far tumor deposit should be from the main tumor? to classify it as a tumor deposit and not the continuation from the main tumor?
There is no number given, how many away from the main tumor. What you have to make sure on histology is that it is not continuous. Usually the tumor deposits, they don't have any infiltrative type of margin. They are more rounded, nodular in appearance. Of course, this is like a general term appearance to it, and they are away from the tumor. And they can look like they are perineural and things like that. That's why you have to make sure it's not perineural, not lymphovascular before you call it a tumor deposit. So basically, look at the advancing age of the tumor, and then from that advancing age of the tumor, if you move further away and you see just a group of tumor cells, clusters of tumors, then that becomes a tumor deposit. It will be separate. Even when you do crossly, you will see some fat in between that main tumor and that. If you just see fibrosis and looks like tumor, you know, because there's desmoplastic creation, okay, if you see it there, sorry, I'm getting distracted. If you see it there, then crossly you look, and then suddenly you will see that lesion looks separate from the main tumor. Then it becomes a tumor deposit. If you feel that the desmoplastic reaction is throughout and those tumor clusters look the same and have that advancing aged appearance to it on histology, then you just consider it as part of tumor.
Okay. Then the second one, if the same, Dr. Nur Hafiza also asked the same question. If the appendix or small bowel directly infiltrated by the tumor, how do we stage it? If there are tumor deposit within the appendix or small bowel, does it count as metastasis?
Okay, so if there is direct invasion from any part of the colon, sometimes you get en bloc specimen, say from the sigmoid colon, you have a tumor that is perforating directly into another part of the colon or small bowel or appendix. This is a PT4P. This includes bladder, okay? This includes the liver if it is at the right at the hepatic fracture, okay? All this, or even into the pancreas. This is a PT4B, right? If you see tumor in the sigmoid, there is maybe tumor perforation there, but the appendix is separate, not stuck together, and there is tumor on the surface, then this is metastasis. It becomes distant metastasis. Peritoneal, so it is PM1C.
Okay, Doctor. Yeah, Doctor, continue. Okay, I hope it answers the question, Dr. Fiza. Then we'll move on. This is Dr. Ng Pui Fong. Yes, hi, and thank you, Dr. Pavi, for the great lecture. For poorly cohesive or signet ring cell carcinoma of the colorectal, do we need to grade tumor budding because this tumor infiltrates in singly and appears as a tumor budding? I think she will have a problem.
Okay, I agree. I personally find this very, very difficult for poorly cohesive and signet ring cell tumors. They on their own is already a poor prognostic factor. So at the moment, there is no guidelines for this yet because tumor budding is pretty new and they are still working on it. So at the moment, we still try our best to give tumor budding for these cases, but if you find it really difficult and are unable to, then you just write a comment saying, in view that this is a poorly cohesive signet ring cell or signet ring cell CAA, we are unable to assess tumor budding. anyway, also it is already poor prognosis for these patients. They will go for neo-adjuvant therapy, adjuvant therapy for these cases, regardless of their stage.
Okay, we'll move on to another question. This is from Dr. Naja. Hi, Dr. Pavirata. Do you recommend reflex MSI testing or the surrogate in all colorectal CA, although it is not requested by our local institute surgeon or onco?
Okay, so I am actually working on this. In Alustar, in Hospital Spina Baya, we did reflex testing based on a set of criteria that were initially recommended. So when this was recommended earlier, we followed that set of that criteria. But at that point, we started doing it somewhere, I think in 2010. But we found that that information was not actually translating into any sort of treatment or management for the patients. So last year and this year, I have been working with the colorectal surgeons and also the oncologists to see which cases that really need testing. Honestly, I'm still working on it. We're having a working group that's going on at the moment. So yes, I am trying to decide whether we need to do it on all cases or not. At the moment, in a hospital Pulau Pinang, we do it on cases that they request. Okay, as I told you previously, we were just doing it for Lymph syndrome, but now it's going to make a difference on a certain stage of diseases. So, and what chemotherapy the patients receive. So technically, we should do it on all cases, but how cost effective and how worth it is for us to do. We shouldn't be doing these IHC stains and reporting them if it is not going to benefit the patients. But based on my discussion so far, yes, the surgeons and oncologists and the geneticists are keen for us to start doing testing. I'll keep you posted. Once I come up with the guidelines on the MSI testing, I will share with you. Certain hospitals already have their own testing guidelines, like HKL, because of the molecular setup there as well. They have a very nice and holistic approach to these cases. They have decided based on their numbers that they are going to do reflex testing for all cases. But I have to look at the cost effectiveness for all the other hospitals, whether we want to start doing it as such.
So
I know it doesn't answer your question yet, but yeah, this will come in the future.
Okay, Doctor. So I think this question is from Dr. Nur Idayati. It's similar to the same question asked by Dr. Nur Hafiza. If there is an addition to small bowel, but the tumor just extend to the subserosal region of the small bowel, sparing the muscularis propria, how to stage it?
Still a pity for me.
Yeah, it's an addition,
as
direct
long as
extension.
It's stuck, yeah, direct, as long as it has peritoneal invasion into the bowel wall, whether subserosal or not, it's stuck, then you call it a PT4B.
Okay, so she also have another question. I'll read from the chat box.
Okay.
For the tumor budding, is there any option if we do not have microscope with 20x objective?
No, at the moment, all the recommendation is at a 20 times objective. So if your microscope does not have a times 20 objective, I suggest that you'll start looking for times 20 objective because you need it for your liver biopsies as well, renal biopsies. A lot of the newer calculations are using times 20 objective. So that's why I mentioned if your microscope does not have a times 20 objective, this assess, you have to go use somebody else's microscope for this assess.
Okay, Doctor, I think we have a few more questions. Are you okay if I just read?
I'm okay. Go
Okay.
ahead.
So this is from Dr. Arfahiza. Hi, Pavi. Thank you for the great lecture. Do you perform MMR immuno on biopsy or excision specimen?
Okay. I personally prefer doing it on excision specimens because I want to look at the internal control and make sure it's working. I see for MMR is difficult. There's a lot of times that it doesn't pick up properly. It's not an easy IHC to do. So wherever possible, I want to do it on the resection specimen to look for the internal control, make sure it's working, and my assessment is appropriate. However, in cases that are receiving pre-operative neo-adjuvant therapy, then it should be done on the biopsy.
Okay, doctor. So this is another question from Dr. Sharil. Hi, Dr. Pavi. If patient has rectal carcinoma and the surgeon submitted additional lymph node from the near the cecum or terminal ileum, which is positive for tumor, doesn't this positive lymph node consider in PN or PM?
If the tumor is in the rectum, then this is a distant metastasis already, so it becomes M.
M, doctor?
Yeah.
Metastatic.
Metastatic.
Mm.
Unless this patient has a synchronous tumor in that side of the colon, then the staging comes separate for the two.
Oh, okay. So just going with this question. So if you, since you addressed the synchronous tumor, if you have a two synchronous tumor, even though if it is the same type, do you open two PROFORMA?
Yes. So each tumor, the closest one first will be your tumor 1. You use a whole PROFORMA for it. Then the second tumor, say patient has tumor in the ascending colon and the rectum. So you use 2 PROFORMAs for it, 2 sets. Okay. Okay. But your final interpretation, the TNM will be the greater TNM.
Oh, we no need to address each tumor.
You can address, but treatment will be given based on the greater TNM. So you can say ascending colon tumor, adenocarcinoma, well, low grade, PT1 and 0. Okay, but and then rectal tumor, poorly differentiated high grade. Sorry.
Oh, sorry.
Rectum, poorly differentiated high grade adenocarcinoma, PT3 PN1B.
Oh, okay. Okay, doctor.
So the treatment for these patients will be given on the higher TNM stage.
Okay, doctor. So thank you. Dr. Khan asking another question. She asked for peritonealized part of colon other than rectum. Is it correct that we can take we take mesenteric margin? Metastatic peritoneal disease means peritoneal deposit with tumor cell. So these 2 questions. If she asks if it is taking mesenteric margin.
Wait, let me read the question. Okay. For peritoneal part of colon. If the surgeon has tagged or they want to know the peritonealized margin, then yes, then you take the mesenteric margin. Sometimes they just give you a nodule, so then you can't really tell them margin unless they tell you where is the margin, right? Metastatic peritoneal disease means peritoneal deposit with tumor cell. Yes, metastatic peritoneal disease means you see tumor cells in that peritoneal deposit. If it is If there is mucinous deposit, then you say mucin deposits, and in your interpretation, you have to say that this patient may have pseudomyxoma peritoniae. So those cases that have a mucinous morphology for your main tumor, you might get mucin pools in the peritoneal surface. Then you need to say mucinous deposit or mucin deposits, which is suggestive of peritoneal myxoma peritoniae.
Okay. Then the second last question, because the last question I will ask the other time. The second last question from Dr. Tana Morgan. For most studies, mucinous carcinoma and signet ring carcinoma are exclusion criteria for tumor budding and poorly differentiated clusters grading. Should we adopt this exclusion criteria?
Okay. So based on the current CAP and RCPET and all, they actually didn't include this exclusion criteria yet, because I suspect when they had that conference on discussion of tumor budding, it was not yet one of the questions that was addressed. So all the recommendations in the CAP and everything, they have not yet included this exclusion criteria. That is why I said when it's very difficult, you just mention that this tumor budding cannot be assessed due to these highly poorly differentiated tumors, because the newer studies recognize this thing and suggest that it be excluded, but the main guidelines has not yet adopted it. Probably in the future they will exclude these things.
Okay, okay, Doctor. So I think I will ask the last question. I understand that tumor infiltrating lymphocytes, TIL, and also the extracellular mucin previously again in the old PROFORMA, less than 50%. Both this is a non-core elements. If let's say we are doing a reflex MSI testing in for example, in HKL, we are doing for all the cases. Since both these entities are actually indicative of a MSI colorectal carcinoma associated with MSI high, MSI instability cancers, right? If let's say we are doing this MMR, can we not report this microscopically? Because MMR is already superior to especially the tumor infiltrating lymphocyte. I'm just asking because it's a tumor infiltrating lymphocyte.
I understand. Okay.
It give a clue.
Yeah, it's to give you this clue and to support your need for this staining. I understand that is what you're asking. So you can not report it, but a lot of the centers don't have this availability of MMR screening. So those centers are going to report it. And then when it gets to the clinician and the oncologist, they are looking at those factors to decide whether we want to do the MMR for those cases. Because at the moment, we as the histopathologists, we are not deciding whether these cases need MMR screening or not. The clinicians are the one deciding. Clinicians and oncologists are the one deciding, you see. So if we don't give them that information, they will not realize that, oh, this case, probably we want to do MMR testing. The criteria for the mucinous more than 50 is for definition of mucinous carcinoma. That was why it was introduced in the first place before the advent of investigation for MMR testing. So that criteria was there long before MMR testing was actually introduced. Only later on they found out, oh, the mucinous differentiation is actually more common in patients with MMR deficiency. So
Understand.
that criteria should be reported because it decides whether you're going to call it a mucinous carcinoma or an adenocarcinoma with mucinous differentiation.
A last question. Just now, doctor said the well differentiated. I mean, the low grade and the high grade tumors, right? The first one is I think WHO mentioned that we will take in account the Lymph differentiated area to qualify it as. Let's say I have a tumor with 60% of showing a glandular formation, but there is a foci showing a poorly differentiated area. So that falls under.
I tend to look at the whole tumor and give a grading system. Even during my attachments, when I asked a similar question, most of them actually prefer looking at the whole tumor and deciding this differentiation and using 50% as the cutoff. So if you see glands more than 50%, then you call it low or moderate, whichever one. And I mean, well or moderate, and it becomes low grade. But if it is less than 50%, then it becomes poorly differentiated.
Okay, doctor. Thank you. That's quite clear now. I think we don't have any questions from the participant.
Okay.
Today, I think it's very. Yes, doctor.
Shared PROFORMA.
Yeah, I already shared in the chat box. I will be sharing in the WhatsApp group and in other groups also. I think today we reached almost 130 participants.
Wow,
both
thank you everyone for coming.
Zoom and also the YouTube platform. So I think this is a very comprehensive and insightful presentation given by Dr. Pavi. I think we should applaud in a usual manner, even though we are in a virtual platform. And I think
we take some pictures?
Oh, okay.
Before your
participant. Sure. I think I'll open for a snapshot later. So I hope we can benefit immediately and start using this excellent PROFORMA. I think thank you, Dr. Pavi, for your contribution, and you can spare some time and effort to be with us and share with us your expertise in the field.
Thank you.